Morning, everyone. Afternoon, everyone. Good to see you. Good to see you. It's my pleasure to introduce Dr. Leslie Morse. Dr. Morse is Professor Chair, Department of Physical Medicine and Rehabilitation at the University of Miami Miller School of Medicine. Welcome again, Leslie. Now, Dr. Morse is a highly respected physiatrist and spinal cord injury researcher, over 20 years of experience. We recruited her from the University of Minnesota, where her research has been funded for 2 decades. She's chairing the department. She chaired the Department of Rehabilitation Medicine at Minnesota, and increased funding by 464%. That's pretty impressive, so I have to say that. And she also won the Gender Equality and Medicine Science Award in 2020. She now leads a top-tier rehabilitation hospital at the Christine E. Lynn Rehabilitation Center. A lot of people, you know that, providing care of over 35,000 patients annually. She's dedicated to advancing rehabilitation medicine and through innovative research, high educational standards, and commitment to inclusion and equity. So today, Leslie's going to be talking about bone health and spinal cord injury, which is so very important. Leslie, thank you for being here today.
Okay, thank you for the kind introduction, and thank you all for joining us this afternoon. I am going to relatively quickly walk through 2 or 3 clinical trials that I have conducted over the past 10 or 15 years, and I'm going to try to leave a few minutes for discussion at the end or questions, but please, if anybody has any thoughts or burning questions while I'm talking, go ahead and interrupt and stop, and we can have a conversation as we go. Okay, so a few disclosures. The work that I'm presenting today has been funded by the Department of Defense, comparative clinical trial for the robotic gait training study, our Minnesota Regional Model System Study, and Craig H. Nielsen Foundation Pilot Grant. I also, if we have time at the end, I'm going to go through some clinical practice guidelines that were developed at the request of the International Society for Clinical Densitometry, and I chaired that task force. I also worked as a panel member for the Consortium of SCI Medicine's Bone Health and Osteoporosis Management Clinical Practice Guideline, and I was a member of the Delphi Consensus Panel that made recommendations on fracture management in spinal cord injury. So I think this group does understand the importance of bone health and spinal cord injury, but for a long time, the thought was that these fractures are relatively insignificant in the paralyzed limb. If an individual is not going to be getting up and ambulating on the limb, why should we care about disuse osteoporosis? And as all of these amazing advances in technology are occurring in our field, I think it's very intuitive that without an intact skeleton, people are really deprived the opportunity not only to take advantage and utilize neurorestorative therapies, but also to take advantage of what I think we all hope may materialize in terms of improvement in neurological function. So that's the first, really, in my mind, important reason to pay attention to bone health. The second reason is that we now have a much better understanding of the importance of the skeleton as an endocrine organ. And I'm going to touch on the pilot grant at the end of this talk that really appreciates the role of osteocalcin, which is a bone-derived hormone, and its activity in multiple other organs. And so if we ignore bone health, we really put at risk multiple bone interactions that can have an impact in systems that we may not appreciate fully today. So I'm going to start with some of the work that I did very early on in my career. This came out of my K-12 Career Development Award. I did work in a rodent model of contusion spinal cord injury. And so we used a severe contusion model to generate paralysis in 3-week-old rats. And then we looked at changes in sublesional bone. So changes in the distal femur and the proximal tibia within the first really week after injury. What we found, and what I think we all know, is that there is multicellular dysfunction in the paralyzed limb as a result of disuse, and this happens very, very quickly. What we see here is H&E staining through the distal femoral metaphysis of injured rats. So we have uninjured on the left and injured on the right. And let me see if I have a pointer. Well, actually, can I use? Can you see the cursor? Okay, perfect. I'll do this. Okay, so this is distal femur H&E stain for cellular identification, and these are osteocytes within their lacunae. Again, we have a very clear understanding of the role of osteocyte in bone cell metabolism. They are the master regulator of cellular activities. They are the mechanoreceptor of bone. They are the cell that senses and transmits information regarding overloading or the loss of loading. And in response, they increase or decrease osteoclastic bone resorption or osteoblastic bone formation in response to the needs that are the demands that are being placed upon the skeleton at any given time. So they are very, very important. They're actually an osteoblast that has encased itself in mature bone and is distant from the bone surface. So again here, we see osteocytes in their lacunae in the uninjured normal condition, and almost immediately, we can detect this change within 3 days after injury. You see massive osteocyte apoptosis. So several empty lacunae in response to paralysis. Yeah, please.
Is there any role on the innervation of the bone for this, or is it pure?
It's almost certainly multifactorial. So bone is richly innervated, both in the well, you know this, bone is richly innervated. And so I would say about a decade ago, it was very trendy looking at changes in neuropeptides in the bone microenvironment. Not a lot materialized from that, but I think that we all understand that it's multifactorial. So there is underlying status of the individual who is injured, hormonal, race, age, dietary, nutritional components, and then this neurogenic component that has not been, I would say, completely characterized, and then the disuse. From my perspective, from all of the reading that I've done and all of the work that I've done in animal models and in clinical trials, for me, the biggest impact on bone metabolism is the disuse factor. So the top slides, again, uninjured on the left, injured on the right. The top is stained for cleaved caspase 3, which is an indicator of apoptosis. And the bottom sections are stained for BRDU, which is an indicator of cellular proliferation. Now, this is looking at osteoblast activity, and we can recognize osteoblasts by their morphology. They're cuboidal cells indicated in white arrows here that line the bone surface. So in normal conditions or in the uninjured controls, you can see multiple healthy osteoblasts lining the bone surface. After injury, you see multiple cleaved caspase 3 osteoblasts. So osteoblast, apoptosis, and in the bottom sections, in normal conditions, we see multiple osteoblasts that are incorporating BRDU, so they're proliferating. After injury, we really don't see any actively proliferating osteoblasts in the injured sections. When we talk about bone remodeling, we think of osteoclastic activity occurring in close proximity to osteoblastic activity. So you have regions of osteoclasts removing old bone, and then you have regions of osteoblasts coming behind and laying down new bone. And in fact, that remodeling is critical. You actually have to have removal of bone to adequately lay down new bone. So in the uninjured controls, you see osteoclasts, which are stained here with TRAP, which is an indicator of activated osteoclasts. So we have osteoclasts in close proximity to osteoblasts. Again, osteoclasts in close proximity to osteoblasts. After injury, within 2 to 3 days after injury, you see a massive influx of activated osteoclasts. And the signals that are driving this, actually, we still don't know what it is that tells the osteoclast to move in and start removing bone really rapidly. One other really intriguing possible or potential consequence is that osteoblasts are required for the hematopoietic niche. So in ablation models, in rodent ablation models, when you remove osteoblasts, you impact multiple facets of hematopoiesis. And so this disuse osteoporosis with the multicellular dysfunction that we see may be a physiologic basis for changes in immune function following spinal cord injury. Yeah. It's not. That's a really great question because we tend to think that osteoporosis is predominantly a disease of older women and older men as well, but we usually think about women. These changes happen in both men and women, in both female and male rodents as well. And so it is independent of sex hormones.
So you know that in space flight, people start with very quickly. Do you think those mechanisms are, say, worse in spinal cord injury, or accelerated in spinal cord injury, or relatively equivalent?
They're accelerated. So in space flight, it's about 1% per month that astronauts lose, and it's obviously multiple, but there is no lesion, so it's throughout the body. Individuals with spinal cord injury, motor complete spinal cord injury, can lose bone at 1% per week for the first 2 years after injury, culminating in 40% loss of bone density. So it is more, and again, adds to the neurogenic component, but I think that the disuse, in my opinion, so we have models of bed rest, we have space flight, and then we have spinal cord injury. And spinal cord injury is by far the worst in terms of the severity of bone loss that occurs. Okay. So the culmination of accelerated osteoclastic activity, suppressed osteoblastic bone formation, results in this very, very severe wasting of both cortical and trabecular bone, which is really interesting. The degree of cortical wasting that's seen so quickly. So again, this is 10 days after injury, we can detect, almost complete removal, if you will, of the trabecular bone, and then significant cortical thinning, and that is unique. So I start this talk with a review of what's happening at the cellular level in the bone microenvironment because it really informs how I approach clinical trial development. And so we know that we have osteocyte apoptosis, we have accelerated osteoclastic development, and we have, or activity, and we have suppression of osteoblast formation. One therapeutic approach that is really implemented when we use drugs, particularly bisphosphonates, is to suppress osteoclastic activity. And so that has benefits, but as I said, coupled remodeling is actually dependent upon osteoclastic activity occurring in the same area as osteoplastic bone formation. And so when we kill osteoclasts, we're not really restoring the normal cellular activities within the bone microenvironment. So from my perspective, the ideal therapeutic approach would be to promote osteocyte survival, to preserve the bone mechanoreceptors, promote coupled remodeling, and regenerate bone if at all possible. If we're in this state with really impacted trabecular bone in cortical thinning, is it even possible to go back to or approach the pre-injury status? So one very powerful osteogenic stimulus or osteoanabolic stimulus is exercise. And for me, this makes a lot of sense that if one of the most important contributors of bone loss after spinal cord injury is the loss of mechanical loading, that this may be an effective treatment option or a preventative strategy if we reintroduce mechanical loading in the paralyzed limb. So the first clinical trial that we initiated to test this hypothesis was a comparative clinical trial, and it was meant to be designed as a dual action, so an anti-resorptive and an osteoanabolic therapy in one arm, and then an anti-resorptive in the other arm. So we used functional electrical stimulation in the paralyzed limb as the osteoanabolic treatment, and we paired that with zoledronic acid, which is a potent bisphosphonate, which does suppress osteoclastic activity. And we compared that to zoledronic acid alone. So we used and I should say this was done in collaboration with a colleague at Spalding Rehabilitation Hospital, Andy Taylor, who really picked up functional electrical stimulation assisted rowing and implemented that in his research program. But you can see that we had a rower that was adapted to to facilitate rowing in paralyzed individuals. So we have a telescoping knee bar that straps around the legs to keep the legs in line, a foot plate, and then an instrumented rowing handle that allowed individuals to fire the stimulation in coordination with the rowing cycle. And then we stimulated the hamstrings in the quadriceps in a cyclical fashion, or the individuals were trained to do this. We enrolled 35 individuals in each arm, so rowing alone or rowing plus zoledronic acid, and the zoledronic acid was given as a one-time 5 milligram infusion. We enrolled adults, individuals, C6 through T12. And so the inclusion criteria in terms of function was so that people could hold on to the rowing bar and activate the rowing cycle independently. We excluded pregnant women because of the potential impact of a bisphosphonate on the developing fetus. And we excluded medications that might impact bone metabolism or the presence of a pressure ulcer in a region that might be impacted by rowing. So ischial tuberosities, shoulder blades. Individuals were enrolled, randomized to rowing alone or rowing plus zoledronic acid. We did a series of screenings. So we screened for vitamin D deficiency and we treated it. If identified, we did a cardiac clearance workup so that individuals were deemed fit to do aerobic exercise. We screened for renal function because it's dangerous to give a bisphosphonate to somebody in renal failure. And in some women, atrial fibrillation has been reported after zoledronic acid administration, and this wasn't an exclusion, but we screened for atrial fibrillation so that we were aware and didn't attribute it to the zoledronic acid. And then bisphosphonates can cause osteonecrosis of the jaw, so difficult time healing the jawbone due to the impairment of the osteoclastic activity. And so we excluded individuals who had invasive dental work that was planned. Everybody who was enrolled and randomized to the rowing arm had to go through a pre-row training. So this was actually a treatment protocol. So we included people who are 3 years or more after injury versus a preventative treatment where we would try to block bone loss after spinal cord injury. So imagine the amount of muscle wasting that occurs in the first 3 years of injury. Not everybody who came into the program could sustain the half an hour of rowing 3 times a week that we wanted them to do with the functional electrical stimulation. So they went through a pre-rowing training program where they could sustain rowing for at least 20 minutes, and then they moved on to the actual training. Standard stimulation parameters for these individuals, again, the motor points of the hamstrings and the quadriceps, and individuals underwent the strength training until they could tolerate the stimulation intensity increase with fatigue to maintain full knee extension. So the protocol was 3 days a week for a year, 30 minutes per session, and our primary outcome for this study was change in bone strength at the knee. So we obtained clinical CT scans through the distal femur and the proximal tibia. And again, the reason that we focused on this region is that the distal femur is the site that is most frequently fractured after spinal cord injury. That's distinct from postmenopausal or age-related osteoporosis, where the hip and the distal radius or the spine is most commonly fractured. So we obtain CTs at 3 time points, baseline, 6 months of rowing, and then after 12 months of rowing. And I actually forgot to, right, after 12 months of rowing. We assessed 143 individuals. We excluded 74, randomized 69, had quite a bit of loss to follow-up. You can imagine asking individuals to exercise 3 times a week for a year. And in our final analysis, we had 10 individuals in each group. Really, what I want you to see from this is that bone density classification, which we diagnosed osteoporosis based on bone density at the hip, and we had really normal bone density for about 30% of the individuals in each of the arms, and osteoporosis in 40% in each of the arms. So either osteopenia or osteoporosis in 70% of the individuals enrolled in this trial. So for the 34 individuals enrolled in the Zoledronic plus exercise arm versus the 35 in the exercise arm only, so considering everybody enrolled, not everybody who completed, we had a fair number of study-related adverse events. We had no serious adverse events, so no hospitalizations or deaths or change in function due to the rowing protocol or due to the medication. The adverse events were more common in the combination arms, so zoledronic acid plus exercise, and that is because 26% of individuals experienced acute phase reaction following the zoledronic acid infusion. And so that means that people basically felt like they had the flu for a couple of days. It responded well to Tylenol, and when we started observing this, we asked people to schedule their zoledronic acid infusion on a Friday so that they would have the weekend to rest. And then we had a large amount of exercise-related adverse events. Again, as you might expect, musculoskeletal pain, shoulder, elbow, wrist, back, hips, knees. We had some pressure injury formation, tachycardia due to the rowing, and we had some stimulation-related autonomic dysreflexia. And interestingly, one individual experienced would ejaculate with electrical stimulation. We only saw that in one person. So we compared the changes in bone geometry and bone volume in the combination group compared to the zoledronic acid only group. And we looked at 3 models. The first model, we included all participants. And you can see that compared to zoledronic acid, the combination group had significantly improved cortical bone volume, cortical thickness index, and buckling ratio. So bone geometry and bone volume was improved in the combination group, both at the proximal tibia and the distal femur. We also looked at a chronic group only, so 18 individuals versus 20, because after in the data cleaning, we realized that 2 individuals were enrolled who were within 3 years post-injury, so they were really considered acute SCI, not chronic SCI. And then we really didn't have enough people in these models to adjust for sex, and so we looked at a male-only model of 16 individuals. But again, the findings are consistent in all 3 of these models, suggesting that the rowing had a beneficial impact above and beyond the zoledronic acid. Good question. And I'll get to that in about 10 slides, because that is exactly it. We're using CT because, in my opinion, small, subtle changes in cortical thickness likely correspond to improvements in bone geometry and bone strength that we probably cannot pick up by DEXA. So, in my opinion, when we're doing clinical trials and the outcome is bone-related, in spinal cord injury. I always use CT as the primary outcome, but DEXA as a secondary outcome. But the question is, all that we know about clinical predictors of fracture are derived from DEXA. So I think there's a lot of work that needs to be done in terms of looking at which has the better predictive value. From this data set and then the subsequent clinical trial, we have DEXA and CT-derived indices. And so we looked at prevalent fracture history and we looked at area under the curve. And as you might imagine, the CT indices performed better than the DEXA-based indices, but the DEXA actually performed quite well. So again, I stand by using both outcomes, but I think that CT is going to get us further in the long run. Okay, so distal femur, proximal tibia, really in cortical bone volume, we have an increase in the combination group. And then what we see in the other indices is really a mitigation of decline over time, which is important. It may have benefits in terms of reducing fracture risk. We really don't know. These are multivariable models. And it is an attempt to look at factors that might be important to consider in an osteogenic therapy. So we know that vitamin D is significantly associated with the amount of bone that can be gained. Age at impact, so higher age, less bone is gained. This leg lean mass in cortical bone volume, I really couldn't explain, and I don't know if it's a fluke of a small data set or if it's a true finding. This is something that we definitely think about and take a look at. Intuitively, I would have said that leg lean mass is probably, the more leg lean mass you have, the more gains that you are able to make, particularly in a therapy that involves mechanical loading and muscle-bone crosstalk. And we see that in cortical thickness index and buckling ratio. So this is the density map of an individual with high or better bone geometry and low bone geometry, and you can really see increased density in the cortex. This is post-intervention, and this is not a pre-post. It's just looking at the bone geometry in an individual is probably more likely to have a fracture due to low bone mass. And then finally, we looked at a dose effect of total rowing. So just in the 10 individuals or in the 8 individuals in the second model who rowed without zoledronic acid infusion. And we can quantify the gains that are made per watt minute, but they're very, very small. And when we convert them to a zoledronic acid equivalent, it's on the order of several thousand hours of rowing to be the equivalent of a zoledronic acid infusion. So from this, the conclusion was, actually, let me walk you through also. This is a simulated failure, and gray is failure, based on geometry and cortical volume. And we see that in this individual, one individual baseline and follow-up post-rowing, there are fewer gray boxes at the epiphysis, at the femoral epiphysis due to the rowing. So that would suggest that this would protect or be protective or convey some reduction in fracture due to the treatment. But as I said, I think that there is a lot of work. I think there's potential for electrical stimulation assisted rowing in terms of an osteogenic effect. I think that we have to think about the mechanics of rowing. We didn't have force plates on the rowers, and so we didn't have instrumented rowers. We can't really tell how the force generation changed from individual to individual and how that really predicted the amount of bone that was able to be laid down in those circumstances. So there is potential, but we took everything that we learned from that trial and we moved into robotic assisted gait training as an osteogenic stimulus. This also was funded by the Department of Defense as a clinical trial. We enrolled again, adults and essentially individuals who could safely fit into the robotic exoskeleton and use it safely. And that included sufficient upper body strength to be able to complete sit-to-stand transfers. We excluded individuals with a lower extremity fracture or contracture, or medications that impact bone metabolism, as well as pregnancy. So this design was a bit different. We had individuals who were randomized. So we had two arms, individuals who were randomized into gait training immediately and then delayed start. So in the delayed start group, we had 6 months of standard treatment. We did assessments at baseline, midpoint, and after the period of gait training for arm 2. And again, three assessments, baseline, midpoint, and final assessment for individuals who went into immediate gait training. Same outcomes. From a bone perspective, we looked at change in strength by finite element analysis, distal femur, proximal tibia, and our final analysis included 19 individuals who had any period of gait training intervention versus 10 individuals who had no intervention. Fairly balanced in terms of baseline demographics for those enrolled in the no intervention or who received no intervention versus the gaining intervention. We had, again, several study-related adverse events, and in this study, we actually had 2 fractures, which we considered serious study-related adverse events due to the change in function that occurred because of the fractures. And I'm going to walk through one of the fracture events that occurred because I think it's interesting to look at and to think about when we're introducing mechanical loading in any of our either clinical paradigms, any of our wellness programs, or any of our research projects. So this was a 36-year-old female with a T4 chronic SCI who was at the beginning of our 3rd gait training session when she complained of chest tightness, chest discomfort, and shortness of breath. She was helped out of the exoskeleton, placed in the supine on a treatment bed in the Peak Center, which was at Craig Hospital. Her blood pressure was 118/72, which was elevated from her baseline pressures in the hundreds for systolic, and her heart rate was 95. Her O2 sat was 88% on room air, and she was found to be confused. Rapid response was called, and she was immediately transferred to our acute hospital for evaluation, and she really went through every treatment imaginable. It was presumed that she had a PE, but the CT was negative. And then they looked in her extremities and found this fracture here at the white arrow. So confusion, desaturation, none of this really screams fracture, but I always tell my research groups, particularly when we're loading individuals in a protocol, please think fracture first, because in all likelihood it will be a fracture. And so I personally think what caused her symptoms was a fat embolism. And her sister, who is a OBGYN physician, was present during this gait training session, and she said it looked very much like a fat embolism to her. So strange symptoms, look for a fracture. This was a second adverse event or bone-related adverse event. Baseline DEXAs. Gary, I'm going to put you on the spot. Do you see anything abnormal in the follow-up? Ricardo jumped in, and so this was a bit peaked. I had seen this on the base, so I did the DEXA scans myself. I had seen this, and this wasn't as bad. But after 6 months of gait training, we have this really just 6 months of calcified bone, which is shocking because we talk about 2 months for a remodeling cycle and a significant amount of time to mineralize immature bone from osteoid to mature bone. And so I was really surprised when I saw this on the post-gating DEXA, and I was a bit remiss in not getting additional imaging. We chalked it up to HO. I think we've all agreed after that this may have been a stress reaction, and so an exuberant callus, if you will, from this person had a significant amount of spasticity in this limb, and I think the tug during the gating basically caused a fracture. Now, this was a lot of change in a short period of time, and just as remarkably, this was gone on the 6-month follow-up. So this mass resorbed and resolved and was pretty much undetectable when I repeated the DEXA. So again, something to consider. So really quickly, at the end of the day, when we consider any gating period versus the no gating period, we had very clear, these are in percentages here. So this is integral bone mineral content, compressive strength index, buckling ratio, and bone strength index. And you can see that we have from 6 to 20-ish% improvements in these bone strength indices due to the gating. If you had asked me if rowing or robotic gait training would have been more osteogenic, I would have said the rowing. So I was actually really, really surprised by this outcome. We looked at density changes in response to the gating. So this is one individual density change. So orange and yellow are high regions of high changes in density, blue, lower regions of density change. You can see in this individual that we really have asymmetrical loading in this one individual. And if you remember, that fracture occurred in about the same place that we have this asymmetrical loading. And so collectively, our interpretation of this, if we think about the Utah paragram of skeletal physiology in an adapted state, bone resorption and bone formation are perfectly matched to the requirements or the demands that are placed on the skeleton. So you don't have any increase or decrease in the adapted state. In periods of disuse, you have accelerated osteoclastic activity, and so you have bone resorption. You remove bone in response to less need. And then in an overloading system, you have bone formation, but you can exceed what is possible in terms of overloading. And when you do that, you get fracture. And I think that is what's happening here. So if we were to really think of robotic gait training as an osteogenic therapeutic option, we have to be mindful, and maybe quite a bit more work is needed in terms of leveling out changes in bone density and making it less symmetrical.
Were you saying that there was a lot of remodeling going on and that made it susceptible to fracture?
Yeah, I think that this fracture, it's possible. It's possible that we jumped right to fracture. We overloaded beyond the skeletal integrity, the capability of the skeleton, and we had a fracture. I actually, again, we need more work to sort out how much change and where is beneficial versus being detrimental. This gets to your question. So we pooled the data across these two studies, and we looked at the relationship between prevalent, so historical fractures, and bone strength indices versus DEXA. And so this is area under the curve, and so proximal tibia bone density really performs quite well compared to all of the CT-based indices. Now, this is prevalent fracture, not predicting incident fracture. So again, it would be really nice to have more information from both CT and DEXAs. And again, Gary, I'm looking at you. I think this is something that we could look at over time in terms of refining our risk prediction protocols. So we have a little over 15 minutes. I think I'm going to quickly walk through some work that we've done in osteocalcin, and then we can either I can take questions, or I can show you some of the other work that we've done. Osteocalcin is a protein that is produced exclusively within within the bone microenvironment. Depends on the expert in the paper that you're reading. But let's say that it is predominantly produced within the bone microenvironment. And this protein, it's used clinically as an indicator of bone formation. So often when we're getting bone remodeling panels, we'll look at, I use osteocalcin and C-teleopeptide as indicators of bone formation or bone resorption. But it also functions as a hormone based on the carboxylation status. So osteocalcin gets decarboxylated in the resorption lacuna. So it is dependent upon osteoclastic activity. And it is the undercarboxylated form of this protein that functions as or hormone with targets in multiple organs. So testis, pancreas, fat, and in muscle. And we know that a variety of medications, including teriparatide or PTH analogs, can impact the carboxylation status of osteocalcin. Therefore, there may be some ability, if in fact it's true that osteocalcin is mediating some of the sequelae following spinal cord injury, we might be able to target the carboxylation status with some existing medications. So the rodent data on osteocalcin is quite robust. So high limb immobilization but not castration results in a significant reduction of undercarboxylated osteocalcin, and lower undercarboxylated osteocalcin is correlated with the degree of muscle loss and muscle weakness. So the downstream signaling pathway is affected by immobilization, and osteocalcin is necessary and sufficient to maintain muscle mass in mice. Let me just click through these. So despite robust rodent literature, there's not really a lot of clinical data on the hormonal function of bone-derived osteocalcin. Again, we know that PTH and PTH analogs increases undercarboxylated osteocalcin levels and decreases body weight and body fat in subjects with hypoparathyroidism. PTH increases and alendronate decreases undercarboxylated osteocalcin levels in postmenopausal women with osteoporosis. And so we also looked at circulating levels of osteocalcin and found that bisphosphonates were associated with lower osteocalcin levels in men with spinal cord injury, suggesting that bisphosphonate use has an impact on the hormonal activity of osteocalcin. So based on collective evidence in the literature, as well as some of our own biomarker work, we conducted a pilot study, really with the intention of generating preliminary data cross-sectionally in two main outcomes that we could use to pilot a clinical trial targeting osteocalcin carboxylation status as a potential therapeutic agent. So we were really interested in the association between circulating undercarboxylated osteocalcin and semen parameters, as well as glucose metabolism in men with and without spinal cord injury. So in this study, we enrolled 30 men with spinal cord injury, 10 men without spinal cord injury. We obtained blood samples. We got glucose and insulin, and looked at HOMA-IR2 as an indicator of insulin resistance, and we looked at both semen count, so sperm count, and sperm quality in individuals with and without spinal cord injury. And I think that Mark Nash may be on Zoom, but he was a consultant on this project and worked very closely with us for the last couple of years on data interpretation and study conduct. So thank you, Mark. Okay, so I'm going to start first with semen analysis in men with spinal cord injury. We were able to collect semen samples in 27 of the 29 participants with SCI who attempted collection. We did this clinically in our urology clinics under the guidance and medical direction of a urologist who does semen collection clinically for individuals with spinal cord injury. From this graph, you can see that 2 individuals were actually able to provide their own samples. 40% of those enrolled were able to provide a sample with penile vibratory stimulation. A number of those failed penile vibratory stimulation alone, but were able to provide a sample with electroejaculation, and 2 individuals were not able to provide a sample. 2 men experienced AD with penile vibratory stimulation and with electroejaculation, and an additional 5 men experienced AD just with the electroejaculation alone. These symptoms in all cases were treated clinically within the clinic and resolved with nitroglycerin. 3 additional individuals reported or had experience giving samples and had developed autonomic dysreflexia, so they were treated prophylactically. Okay, so semen results for SCI. We looked at individuals who had sperm present, but a low sperm count, were invited to come back a week to 10 days after the first collection and try to provide a second one. And I should say, of the 27 semen samples that were collected, they were all abnormal. So they were 20% were abnormal due to low sperm count, 35, close to 40% were abnormal due to abnormal vitality, motility, or morphology, and over 40% just had no sperm present at all, so azoospermia. This is compared to the 10 individuals with no SCI, where 80, close to 90% were normal, and we had 2 individuals with low motility, vitality, or morphology. In terms of glucose metabolism, we had around, actually the findings, the differences were less in terms of glucose metabolism than semen, and I guess I was a little surprised by that as well. We diagnosed prediabetes or diabetes based on hemoglobin A1C levels, and then insulin resistance based on the HOMA-IR2 results. And so 60% of men with spinal cord injury had insulin resistance, or compared to just over 50% of those without spinal cord injury, and prediabetes incidence was higher as well. So now that we know that we can safely and effectively collect semen samples, we know that about 50% of those semen samples from men with spinal cord injury either have low sperm count or poor morphology, mortality, motility, or other semen parameters. And we know that we have a high prevalence of insulin resistance and prediabetes, as well as bone density. I didn't summarize the bone density results, but you can imagine that about 70% of the men enrolled with spinal cord injury had osteoporosis at the hip. So the question is, and the primary outcome is the association between semen parameters or glucose metabolism and undercarboxylated osteocalcin. And we haven't done that analysis yet. So the next time I come back to talk, hopefully we'll have that finding. But if we find a significant association, or probably not even significant in a pilot study, but if we find something that is interesting, the next step is I'd like to shift that association with teriparatide. And I put this here because the last time I looked at teriparatide in spinal cord injury, there was what I thought was an interesting paper on blood-brain barrier in SCI with teriparatide treatment. So raising the possibility that this might be an interesting emerging therapeutic for neurorecovery. I've got like 100 more slides, but I think you would all appreciate if I stop here and Any questions, thoughts?
Yeah, I mean, I super enjoyed the presentation and just all the different systems that you sort of referred to. So, I really think we need to try to begin to put these system pieces together in a kind of a systems medicine biology.
Yeah.
framework.
Yeah.
Just my comment.
Yeah, no, I love it. We'll look to all of you to work with us on that.
What do you think about whole body vibration? That's just like differentiation. I'm working with a group in Bronx, New York City, we're coming around with, looking at that in animal studies.
Mm-hmm.
So it's my understanding that early period or
Lots of literature. Clifford Rosen, right, is the vibration. I think he's a surgeon in Maine. But yes, there's a lot of literature, basic bone biology on the impact of vibratory stimulus to promote osteoblastic activity and to preserve osteocyte function. And there's been some interest in clinical trials. Obviously, you would want, fracture is a real consideration if you're standing on a vibratory platform. So being able to safely administer it. I actually don't know if lying down on a platform would have the same effect on the legs as standing, but definitely the basic biology, the mouse literature is very, very supportive. And there are clinical trials in other systems. Kathy Craven, who's a colleague in Canada, ran a vibratory stimulation bone study in spinal cord injury about 5 or 6 years ago and never published the results. So that suggests that either it was negative or they had problems with retention. And then I can think of one case report, I think from Bill Bauman's group actually, that shows increases in, and it may not be Bill, it could be somebody else. But yeah, I think it's promising as long as we can do it safely.
Who's the guy who, Turkey guy, or Indiana, Ohio, with the collaboration of turkeys?
Turkeys.
That's where,
Shields, no. Richard Shields is in Indiana. That's as far as I can, yeah.
now they just, this is, they just published a couple of months ago, the group in Calgary using anti-sclerostin antibodies.
Oh, yeah. Yeah, we didn't even touch on sclerostin signaling, but yeah,
But they did get some pretty shocking
improvements,
results, like 10% increase
yeah.
in lumbar spine.
Hi, Helen Bramlett, I'm one of the authors of the study that Tom was talking about.
Yeah.
So we did, this was 10 years ago, we did whole body vibration in rats. We did it, obviously, the scanning on the vibration platform, we started 28 days after SCI rats. And they had whole body vibration 5 days a week, twice a day for 35 days. And that was with Mike King and Chris Cardoza and
Yeah.
Bauman up at the Bronx VA were collaborating in the study. But we saw improvements with low intensity vibration in terms of precursor turnover of bone marrow, cells and stuff, and some other biomarkers and genetic markers and stuff. So it showed some promise and stuff. We didn't see a lot of change in the functional testing, but granted we were doing the BDV and it's improved somewhat, but biologically we saw a good improvement.
Mhm.
And some muscle stuff too.
Yeah, nice.
So osteoporosis is known to improve cognition.
Mm.
Some literature is there, so do you have any idea on that? And the second question is regarding serum. You are showing glucose metabolism. Is there any data on fructose metabolism? Because serum has more fructose than glucose, so
Yeah.
that could be interesting.
Yeah, that's interesting. So we have serum samples and plasma, serum plasma buffy coat from everybody in that study. We do not have, if semen was preserved, it was given back to the participant for their own use, and so we don't have that. I think I had the brain on my image of the multiple organs. And I'm really, really interested in cognition after spinal cord injury from a lot of different perspectives, mainly what impact might exercise have, what types of exercise do we need to introduce to preserve or improve cognition, and so very, very interested in that. And we do not have, we tried to conduct a statin, so we were interested in statins and bone health and cognition, and I think pain might have been secondary outcomes in that clinical trial, and this was an acute SCI, because statins basically target the same pathway that bisphosphonates do and have a similar function, though actually they're dual, they're combination. They have an osteogenic and an anti-resorptive effect, and so in theory they're probably more effective than bisphosphonates. I don't think we had elements of cognition in that trial either. So something that I mean, we've talked about having kind of a large data a protocol where we're getting lots of different outcomes, and then we can look at osteocalcin and cognition, or diet and DNA methylation status, or we can do some innovative exploratory studies within that, and then use it to support larger trials or larger studies.
Additional question will be, osteocalcin gets affected by hormones, particularly estrogen. So what if that autoconception or hormone replacement might have one of your study inclusion criteria clearly said that unwilling to use contraceptives.
Yeah.
And I wasn't sure why that was kind of.
So those the two intervention, the gait training and the FES rowing, we excluded pregnant women. One, because the bisphosphonate was given as a treatment, and that will impact skeletal development for the fetus. And so the second one, I just really didn't want women falling and having an adverse event. I mean, we had falls in that study, and so I didn't want to impact potentially. But we're on time, so we can talk more. I mean, I love talking about bone health, exercise, and spinal cord injury, so please reach out.
Mark, can you hear us? Mark Nash?
I can hear you.
Okay, so he had about 20 questions, so. Maybe,
I can go, I mean, if you're all, first, let's just say that I think that bisphosphonates do actually work quite well in spinal cord injury. It's just that we don't have sufficient clinical trials. We don't have fracture as an outcome. Of the handful of studies that I can think of, particularly the group from Chicago, it was a combination treatment with an exercise modality and a bisphosphonate. They actually show gains similar to what we show. So in cortical bone volume, you do actually have improvements in cortical bone volume in response to the zoledronic acid plus the rowing. But I'll have to put my glasses on to read this. Bisphosphonates don't work terribly well. Are you interested in looking at newer PTH analogs as monotherapies or in combination? Yes, I am. I mean, I'm interested in mechanical loading and any, so Ricardo mentioned sclerostin antibody, which is very, very effective in postmenopausal women. Denosumab, so the RANK ligand antibody is also, there is one study in, I mean, I can come back and give a talk on therapeutics clinically in SCI, but Mark, we can chat more about that.
Can you hear me at all? Can you hear me?
Yeah, we actually, with the EXO, we put sensors in people's shoes. And so we do have pre-post loading data that I could share with you, Mark. But both. Loading forces are most effective when they're dynamic and cyclical. So walking should be more osteogenic than standing. And in fact, there has been no clinical trial that has really adequately demonstrated the osteogenic effect of static standing. Though it should be osteogenic. Okay. All right.